So for those of you that don't know me, I'm Elizabeth Skoy. I'm the director for the Center for Collaboration and Advancement in Pharmacy, or the NUSU CAP Center. A lot of familiar faces, people that have been to our symposiums before, as well as some new faces. So we're just really excited to have everyone here today to join us. Usually I give a little talk and an update of all the things that the CAP Center has done, but today I'm not doing that. I want to really go towards more of what the pharmacists and the individuals that are on the ground and doing innovative things in their practice settings can talk about to highlight to us, to give us other opportunities. Just as a recap, really quickly, this is our 4th CAP Center Symposium. Our first one was a kind of a gathering of all different stakeholders from across the state, trying to figure out what it is that pharmacy needs to do to move our profession forward. The second symposium was focused on, from that first symposium, we learned one of the things we need to do is to partner better with our third-party payers. And so we had a symposium that was kind of very focused on bringing third-party payers and pharmacists and other collaborators to the table. And a lot of really great things came out of that meeting. Some changes to what we're doing currently in pharmacists and reimbursement and Medicaid, as well as we're still continuing some of our partnerships and have some of our third-party payer partners here today. So that was our second symposium. Our third symposium last year was focused on implementation science. This is a really big word, but it basically means we have all these programs, we have all these projects and these ideas, and how do we actually get them to be implemented and sustainable versus just these never-ending pilots. So we had a speaker come in as an expert in that area. So now that we've had those three, our fourth one here is finally to kind of that accumulation of, we have some really fantastic projects going across the state, as well as potential new opportunities with state laws that are coming into place in our state. And so what is it that we can do moving forward and how can we expand our practice? And so this is actually the first time that we've opened up our symposium to all pharmacists across our state. And just said whoever can come, and we've had people actually travel from across the state to come today, and really excited to have you here. So with that said, I am going to introduce our first speaker. Jake was gracious, Jake Galdo was gracious enough to come. He was, he's from Alabama, right, Jake? And then was in Washington, DC for the Joint Commission for JCPP meeting yesterday, and then now flew in last night to Fargo, and then is heading back out again right after this today. So really gracious that he's come and spoke to us. But I've seen the more people I talk and say that Jake's speaking, I've gotten messages from people that say, oh, I met Jake here, and oh, Jake's great, and all that. So it's funny what a small world that it is in pharmacy. But Jake is doing some really fantastic things with community health workers in pharmacy and billing opportunities. It's kind of the person that really started and initiated this. And so we are really grateful to have him come here today and speak with us. So with that, I'm just gonna stop talking and turn it over to Jake. So there you go, Jake.
Thank you. Okay, how does this work? Lisa, how's the mic? Does the mic work, Lisa? You're in the back. It sends, okay, good, awesome. And we have slides, and Lisa told me I click down to move forward. Lisa lied to me. I click up. No, I have to, it has to be turned on. And then we go down, still a lie. Then we go up. Lisa, this is the other thing we were going to do. Next slide. Maybe it just needed, no, it's on. I broke it.
Amy, do you have any ideas?
I feel like it needs to click. I'm on PowerPoint, and it's not controlling. See how it's messing with the slides?
Oh, yeah.
Okay, now click it. Click, 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 click. Yeah, you did it. Thank you. Jamie fixed it. Right. What's really fun is this is not CE. I can say anything I want, and no one can get mad at me or yell at me. Now, I have learned a couple swear words recently when I walked into today's room. I'm going to share those swear words with you, just so we're all on the same page. Optum and CPESN. Some of you really know what I'm talking about. Some of you have no idea. That's okay. Just know that those are kind of swear words, and half of them are on the slide right now, which is kind of awkward. All right, see where we're going with here? Okay. I'm a pharmacist by training. I'm from Alabama. y'all. There, see, now you know that I'm really from Alabama because I sound very Southern. I grew up in Atlanta, which is not the South. My mom was from Ohio and my dad was in Cuba, so they met in the middle geographically. Okay. That's how that works. I was really confused right now. Like, how is he like this at 9 in the morning? All right. So Elizabeth was like, hey, I don't have a bio for you. And I said, that's fine. I can do my own bio. So I'm going to do my own bio really quick. I'm the CEO of a company called Segura Dot. We create and implement quality measures for pharmacies for value expression. We're going to talk about that later. Within that, we have a DBA, or doing business as, which is CPSN Health Equity. So we're not CPSN USA. We are our own network under the USA umbrella, and we do health equity stuff. And we're going to talk about that as well, and why that helps us in some areas, but may not be perfect in other areas. Cool? Okay. So what's the fun? This is a very vibrant slide that you can see very, very well. I'm going to ask the people in the back to read it out loud to me because I don't think I can read it where I'm at right now. But what I want to call out is the top line. The blue line is the life expectancy on our x-axis versus the cost on our y-axis. Or I just flip that. Y is up and down, x is that way. So blue line is how much money we spend for life expectancy in every other country in the world. So they spend a little bit of money and they have good life expectancy. The green line is us, also known as the United States. We spend, do what? Oh no, I clicked it. I clicked a lot of stuff. How does that happen? There we go, keep going. Okay, don't point and click. Okay, so that's us. We got a problem. That's what our fuss is all about. So we're going to start here with the patient case. I have done this in front of pharmacists at McKesson. I've done this in front of pharmacists at Syncora. I've done this in random CEs. I did this at JCPP yesterday. So all of our executives for all of our national associations, just we're all on the same page of who that is. You have two patients. It is one married couple. Their pharmacy has identified slow payment on their account. This past winter, their HVAC system broke, leaving them with, quote, an ungodly bill. It says outrageous because this was used for CE and I had to change it, but the community health worker defined it as ungodly. So we're going to stick with that. It's an ungodly bill. Their roof has to be replaced. Both patients' walkers are broken. They need lawn care at their house, and they need a bathroom remodel to include a walk-in shower for safer bathing. There are 6 items on our screen today. Starting with number 6, or I'm going to count down from 6 to 0. Raise your hand if there are 6 issues for pharmacy here. Raise your hand if there are 5 issues for pharmacy. 4, 3, 2, 1, 0. All right, you failed as well. Fared? You're going to fail in a second. You fared as well as JCPP in that you failed this question. The first prompt is the pharmacy has identified slow payment. Is that pharmacy centric? They're not paying their bills. So yeah, everyone should have said at least 1, but that was not the unanimous answer here. Let's go with lawn care, because that's a fun one. Is that your responsibility in the pharmacy? No? Okay. Is it the physicians? No. Is it the health departments? No. Okay. Is it the insurance company? No. Is it the quality improvement organization? Because I found out there's a QIO in the room, so I'm going to call you out really quick on that joke. Is it the quality improvement organization's responsibility? No. Right? We're saying it's no one's responsibility. Guess what? It is now all of our responsibility. If we all say not it, then we're all it. Why does that matter? Because the patient's ambulance can't pick them up to take them to dialysis because they can't get the gurney across the lawn. So yeah, that's actually a real story where we had to have a community health worker contact a local church to get lawn care to mow someone's lawn so that dialysis could occur. Think about that in the value expression. I just helped someone with lawn care. The pharmacy mowed a lawn and helped the patient stay out of the hospital because they had dialysis services. That's health equity. And there is a slight nuance and difference between equality and equity. Equality is everyone gets the same thing. We sometimes see this example where people are trying to look over the fence at the baseball field and everybody gets one box. And so the really tall person can still see. The middle-sized person, that's the official term for it, can maybe kind of see if they get on their toes. And the smaller person has no idea what's going on. That's equality. Equity is you give everyone the resources they need to have the same opportunities as someone else. So in this model, everyone gets a bike that best fits their abilities. So that's why we talk about health equity. A year ago, Deloitte, one of our big major consulting firms, so one of the big 4 consulting firms, actually had this article come out. The role community pharmacies can play in reducing health inequities. That's kind of cool. Now, my bias is I helped them with this. So I was one of the people that gave them recommendations. So that's the spoiler on what they're probably going to say. But notice that this was a year ago, a major consulting organization that consults with employers, with the federal government, with local and state government, is saying we should probably be looking at community pharmacies differently. So then the challenge is, what are we doing to capitalize on what everybody's asking for us to do? So what is the big deal? In that Deloitte article, they said that health inequities account for, $320 billion right now. So we as a healthcare system spend about $320 billion a year on health inequities. Now it's a spoiler at the bottom of the screen, so everybody eyes up really quick. How much do we spend on drugs every year? Now it's at the bottom of the screen. Everybody look down and actively engage with me. $320 billion. We spend the same amount of money on health inequities as we do on drugs. Imagine in every single pharmacy that you're at, in every type of practice setting that you're at, if you just doubled the amount of money you got. You get 50% from drugs, 50% from health equity services, because that's the pie that's sitting there right now. If we don't do anything about health inequities, it's going to be $1 trillion by 2040. Just as a random aside, because again, we're not in CE and we can do whatever we want here. Does anybody know how much hospitalizations cost the US system? About $1.3 trillion annually right now. So what's really scary is, even though we say $1 trillion and everybody's like getting some heart palpitations, stomach drops, right? Like that's a lot of money. But that's still not the amount of money that we spend on hospitalizations every year in the US. So there's still something wrong with the system. This is just part of how we can fix it. So what are social determinants of health? We have the official WHO definition at the top. The social determinants of health are the conditions in which people are born, grow, work, live, age, and the wider set of forces that shape our daily life. We have some other slides with some more definitions and some of those numbers there, but this is effectively the air we breathe, the food we eat, the friends we have or don't have, the water we drink, the places we live. Is anybody here a Brandon Sanderson fan? Well, that's just sad. Y'all should be. This is going to go really well. So we're going to keep leaning into this one. I even have Brandon Sanderson socks on right now to show like I was ready for this. And you guys clearly aren't, but that's okay. He is a fantasy author, so this is obviously not my crowd, but we're going for it. Yeah, okay, thank you. Okay. He has one of his worlds he writes his books on. There's just like a haze across the entire planet. And you can't see, it's almost like the entire world is covered in fog. And it's like a reddish fog. Does anybody remember when there was a forest fire in Canada like a year or two ago, and New York City looked like it was a reddish fogged city, right? So obviously that was a Brandon Sanderson world that nobody gets that reference on, and so we're going to skip past that. But what I want us to focus on is social determinants of health are the air we breathe. How do you think people with asthma were faring in New York City at that time? And was it the random person in Brooklyn or Manhattan or the Bronx? Was it their fault that the air quality was bad? No, There was a forest fire somewhere else, yet it affected their health. They were unable to breathe. They had to go to the hospital. They needed new asthma treatments. Their COPD flared up. Something was going on that wasn't helping them. And so let's think about what this really means in healthcare. In Philadelphia, zip codes that are 5 miles apart, there's a 20-year life difference in expectancy. 20 years. To put that in a different framing of it, what's the average lifespan of a US citizen right now? 77 or so, right? Like somewhere around there. I know there's some gender differences, but we're just going to stick with 77. What is 77 minus 20? 57. Okay, good. We're pharmacists. I was really hoping we could get that one correct. All right, 57. Do you know what that is? Not retirement, which means you die before you retire. Life expectancy is 77, but if you're in Philadelphia and you're in a specific zip code, you live 20 years less than everyone else. So you only live to be 57. How many did I just call midlife right now and they're really mad at me? Huh? Because that's what I just did. In Miami, it's a 15-year difference. In Richmond, Virginia, it's a 20-year difference. That's surreal. So why community pharmacies? Why us? Because our practices are located in the middle of where people are born, grow, work, live, and age. We are there. We are in the communities. We know the communities. We know what's going on. We can mitigate that 20-year difference. I love this picture, by the way. This makes me incredibly happy. My friend Tripp and I often argue, what is a better picture? This is my personal favorite. What you don't see is like right here, there's a little old dude with a beer can between his legs waiting for his vaccine. Tripp likes that photo. I like this one. That's actually his patient. That was his resident last year. I don't remember her name. Let's call her Miss Sally really quick. Miss Sally only has that wheelchair. That is how she gets around town. Nothing else. There's no car. There's no Uber. This is a one street-like kind of city in Charleston, Missouri. It is Charleston, Missouri. As we talk about the changes in healthcare and what's going on and where we need to think about local healthcare and community health workers and the local care that we deliver and local network design, her insurance in 2025 has decided that her preferred pharmacy is a county over. There's one pharmacy in that county, Tripp's, his dad's, and they're not in network. They were kicked off. So the only pharmacy she has access to now is 14 miles away, which I'm pretty sure she's not going to be able to get to. Those are the challenges people are facing right now, right? And so here we're getting shots in arms. We are doing vaccine hesitancy, vaccine clinics, and we're going to person's homes and we're helping close gaps and we're providing high quality care. And now, because there's a community health worker taking that photo, she's talking to Miss Sally, finding out that next year her insurance isn't going to be in that county, and they are finding solutions to it right now. Because it's all about making sure we have local healthcare and local patient care support. Only 20% of our health outcomes as an individual is attributed to the quality and access to healthcare. 80% of our health outcomes are derived off of social determinants of health. The majority of our health is the air we breathe, the food we eat, the places we live, the friends we have. Hard stop. That's what it is. So we start to think about how we need to change our practices differently. How do we need to get paid differently? Yes, I'm allowed to say the word paid. Again, not a CE. What I found out yesterday after we did a similar presentation like this to JCPP, apparently no one says the word paid to them. And we spent an hour and a half telling them how they need to get paid. So that's going to be a theme because we do need to get paid for what we're doing. And so how can we capitalize on the $1 trillion problem that is that 80%? How can we generate revenue at a pharmacy to sustain that? And how do we help our communities? Because currently everyone's looking at it as a call center. Do call centers work in North Dakota? No, they don't really work anywhere. In Tripp's community and probably in your communities here, your patients have a cell phone. And that cell phone has 20 minutes, probably more than that, but let's just go with it, has 20 minutes a month. Are they going to pick up a random 1-800 number to talk about sexual orientation, risky behavior, food insecurity with a 1-800 number call center person for 45 minutes? No. So why do we think a call center works? When pushed on that, major payers will say, we top load all the calls at the beginning of the month while they have minutes. Probably not the solution we're going for. There is a business case around health inequities, and it is a joint business case with not just pharmacy, but all of our other colleagues in healthcare, the insurance companies, the PBMs, the health departments, the QIOs. Everybody can get involved, health systems. Housing insecure persons visit the emergency department 5 times as much. So what can we do about that? $77 billion in medical expenses is attributed to food insecurity. $77 billion is for someone that is food insecure. Do you guys have active military in North Dakota? Yeah? Do you know that 1 in 5 active military families are food insecure? Our military doesn't have enough food. I don't understand that. Social isolationism, being lonely, is as damaging to your health as smoking 15 cigarettes per day. In North Dakota, I believe you have a lot of tobacco cessation programs, right? You have collaborative agreements, you get paid for that, that's a win. So you're getting paid for tobacco cessation. All right, well then I want to get paid for bingo. I'm addressing loneliness, that's as damaging to our health outcomes as smoking. So if I can get paid for tobacco cessation, why am I not paid for playing bingo? Right? We have a delivery driver in California, and they play poker with their patients as they deliver drugs. So on month 1, here's card 1. On month 2, here's card 2. And they play poker over the period of time with a group of patients, all asynchronously and in different areas. But that's engaging them in a conversation. And over 3.5 million Americans miss or delay medical costs due to transportation, which is $150 billion a year. So let's just briefly add up 150 plus 77. Go, pharmacists, go. 225, right? Really 227, but 225. Do you know what that's close to? The 300 billion we're spending on drugs every year. We are spending just as much money on food insecurity and transportation issues as we are on medications every year. Yet, what do we hear about? The cost of drugs. Something is misaligned in this conversation. So in my network design, my wife works at Eli Lilly. Don't stone me. Talk about that later. So she works at Eli Lilly, and so I have Eli Lilly health insurance. And my network design says that I have to go to CVS or Costco. So I go to Costco. I don't really love Costco. My wife does. I don't, but go to Costco. And we have to get our medications there. So I get my brand name inhaler there, which is fine because the pharmacy that I work at back home was getting a $200 loss on that inhaler. So yeah, I'm not going to fill it there and make them lose $200. I'll take it somewhere else. So I get it at Costco, and they text me the other day for my refill, and they offered me delivery services. Costco offered delivery services. And I was kind of interested in that because that's not something you really hear about, right? All right, so then I clicked it and said, okay, if I want to do delivery, how do I do it? Do you know what their delivery service is? Instacart. Do you guys know what Instacart is? Okay, I'm not sure what's here or not here, right? I knew Costco was here because it's across the street, so I felt comfortable with that one. Instacart. Do you know how uncomfortable I felt that my pharmacy was going to give my drugs to a 1099 person working at a different company called Instacart to deliver me those drugs? What if I had a refrigerated item? None of that made me comfortable. Yet there's $150 billion in missed drugs. So many of the blues in various states will pay Uber to pick up patients and take them to their appointments. Yet why are we in pharmacy delivering drugs for free? If Instacart can get paid for it, if Uber can get paid for it, why are we not considering the fact that pharmacy should get paid for delivery services? So the moral of this part is that there is a national focus on investing money into social determinants of health to start to save lives. And we can start to look at this from a population health perspective. We need to start thinking about this from a community diagnosis perspective. If you look at today's agenda, I have 50 minutes of lecturing, and then there is a solid 30-ish minutes of workshops. Technically, you are stuck with me for that entire circle of time because we have active learning built in. Who was excited for homework today? Who was excited about the people at your table and you're like, oh, I needed that gunner that was going to answer the questions for me because that's going to happen. So our first game that we're going to dig into is looking at your community and comparing communities and doing a community diagnosis. Part of that gets into the Social Vulnerability Index, or SVI. The CDC is now producing an SVI. What are the burdens of disease, the health-related social needs at a county level in our communities? So I want you to start to do that. Now, I've played around with North Dakota. Some of the data's there, some of the data's not there. So first thing, that's a business opportunity. Pharmacies collecting the data that the state needs to report to the CDC, that's a business opportunity. Because we're in our communities, we're talking to our patients, we should be looking at that. So I want everybody to open up their computers, pull out your cell phones, and you're going to go to the CDC places. So just Google CDC places. This is our active learning. Like, it is straight up here, community diagnosis. I'm not joking. Elizabeth told me we had to do active learning. We are doing active learning. Okay, pull out your stuff. You can even go to your website. Go to just Google CDC places. It probably is like cdc.gov/places, but I'm not 100%, so I don't want to say it out loud. But go there and just start to click around. At the very bottom, there's an interactive map. So you can click that interactive map. You can go to the county level. You can click in a whole heck of a lot of different things. You can also do a county by county comparator at the very top where it says compare my county, and it just gives you data. I know I just said to do this and I'm still talking and I need to shut up, and I'm going to say one more thing. My personal favorite quality measure in this system, I have a lot of fun quality measures that I like. My favorite in this system is the percent of persons that have lost all teeth under 65 years old. So one of the games I like to play when I give this as a prompt for people to dig into it is who here lives in the county or region that has the least amount of teeth on a percentage base, right? Because if we say per capita, we could just argue Fargo is the big city, so there's a lot of teeth loss, right? But what is your number? And I'll come back to a spoiler on that in 1 second. Hey, Lisa, question for you as you're leaving, because that seems like a really appropriate time to ask you a question. Do you want me to turn that off and present a website and do this in real time with people? Okay. Okay. That's fair. Right, so it is on the screen. It is on the screen, just as a heads up. Still works. But comparison report is how you do county versus county versus county. And that's where you're going to find your teeth measure. If you come down, is your interactive map, which is also fun. So just highlighting that as you're playing around. Sorry to interrupt. If I had to pick 2 counties in North Dakota, what would they be? I don't care. Whatever you want to do. Okay, so Cass County, got it. Indy? Eddie, with an E? Okay, let's do that one. Your asthma is so bad compared to me in Alabama. Oh, well, that sucks. Fair enough then. Okay. Where's Cass County? Fargo? They're better than the national average on T-balls. See? It's not all bad up here. That's actually not the highest I've seen. I've seen a 40%. Yeah. Right, you need to like brag to everybody. You have the highest rating on taking blood pressure meds. You're getting your patients to take their meds. Right? You're doing your job. You're in your county, which you said was really poor and like struggling, but they're on medicine because of you. Right? That's a win. All right, what's also funny is look, Cass County has higher binge drinking than Eddie. College. Dang kids. All right, so this is what's really fun. You guys see what's going on right here? Feeling socially isolated. There's no data for North Dakota. So there's a paucity of this health-related social need data in the state. So like that's a business opportunity. Somebody should pay you to collect that. Hey, everybody. I don't know why I'm going to yell. I'm on a mic. Hey, guys. Hi. Hola. That's how you go into the next slide. So I can't do that. Otherwise, the slides advance, right? All right. Does anybody want to share something crazy that they found? What's something surreal that you did not realize about your community that you now know about? I think the academicians back there are like really into it. That's our academic table, right? You guys are academia back there, right? Because you're super excited. Yeah, okay. So I'm sharing stuff that I'm looking at, and I have US Census, Shelby County, Alabama, which is where I'm from, Cass, North Dakota, which is here, and Eddie, North Dakota, where she's at. I don't even know your name, but she's there. What's your name? Madison's there. Madison's and Eddie. Okay. I'm in Alabama. You would think that we have no teeth, right? Just generally speaking, that is the perception. So I was doing this in New York City. Guess who had more teeth? This guy. That's why I like this. We just have cognitive biases. We think Alabama has no teeth. Yet I have more teeth than Brooklyn. That is a win, yes. That's the, okay, so let's play with that next. I want to play with that one. CDC, I don't know what's called out. Like, legitimately, I don't know, because like, this is all public health data. It's coming through health departments, it's coming through the CDC, and I have an idea for you. And I'm going to come to that. Number two, we're going to call Madison out again. She said, pick my county. There's a lot of, it's hard. It's rural. There's not a lot going on. All right. I don't know where that is. I know nothing about it. All right. Do you know what she's crushing at? She has a really high treatment of hypertension. She beat the national average. She beat Fargo. She beat Alabama. So she's doing a great job. So we need to think about the wins and the losses or the areas for improvement. This can help us in a lot of things. So to your specific question though, what I got really excited about when I kept scrolling is I stopped right here. Feeling socially isolated among adults 2022. There is US data. There is Shelby County data. There is no North Dakota data. So I don't have the answer for you on this one, but I have an idea. You guys have a really cool state where you are all kind of here. You have one state association, you have one school, you have a bunch of pharmacies all working together under umbrellas to do really neat things. You work closely with your health department, you work with your QIOs, you work with a variety of different organizations and payers. The CDC wants this. Can the CDC allot a stipend of money for the collection of health equity data? And it's being driven by collection at community pharmacies for their communities, for their patients, that is then rolled up to the Health Department of Health, that is rolled back up to the CDC. Right? It's a gap. Everybody needs it. Why is that not an opportunity that we're going to try to capitalize on? So to me, that is like the first thing. If we're thinking about health equity in the state, it's not, I want to start doing bingo in every community. I want to start a senior center. No, I need to know what the disparities in my communities are. And to do that, I need data collection. So can the CDC do a grant to the state to collect the data through pharmacies of all places? So business idea one, because again, we can do business ideas, not CE. Feeling good? Okay. Anybody else have anything that they want to share about that fun activity that we did? Yeah.
I know that this data would come from mostly all-based something. They didn't come from every county in every state. So you might have five states from a survey, which then would be extrapolated. These are estimates, but they're well validated. So just wanted to add the source would be census and then the purpose survey. That's the main source.
Thank you.
Here.
Do what?
Purpose has really struggled over the last couple of years to get data. There's a lot that can't support.
Yeah. It's interesting.
But it's well validated, been chronological for decades, so it's really important data. So don't be dissuaded by the fact that the county would be being every truth and every model. But
Rude. Okay, that is our idea one from our first breakout, which is community diagnosis, know your communities. So next up is getting a community health worker in the pharmacy. And why do we even talk about this? What is this? So I'm going to pause this here in what I'm calling a pharmacoequity model. Now that model will come up later in the slide, so we're going to pause on that, but I wanted you to focus on the left-hand side. Who here reads a good old 10K for funsies? All right, am I the only one that actually reads anything in this room right now? Or am I just like completely off the mark in what we consider fun reading? So a 10K is a comprehensive report filed annually by a publicly traded company about its financial performance, and it's required by the SEC. Has anyone read the 10K for Walgreens recently? Does anybody watch Walgreens stock price? It is currently trending at like the 1990s level. It's so bad in pharmacy right now, and I'm saying this amongst pharmacies, that there are some like rumors, and this is unsubstantiated. I am rumor mongering. Please do not go buy stock in any of the things that I'm saying. Like, I'm saying this is the stuff we hear, that like there's a question if Cigna will buy Walgreens right now because they are tanking that much and they don't have the cash flow. So reading 10Ks are really interesting on that fun note. Everybody's really sad now. Sorry. If you look at a common traditional pharmacy and you look at a 10K from a Walgreens, CVS, or Independence, and how NCPA even does it, we see a breakdown of prescription sales and OTC sales. 85, 90% of my business is from prescription sales. The other 10, 15% OTC sales. And that's why we're struggling right now. Because dispensing a drug is a loss leader. Barely break even if possible. So instead we have to diversify and we start doing clinical service sales. So how many of you do clinical services? You do MTMs, you do diabetes self-management education, you do tobacco cessation, you do these other things, right? How do you categorize that on your books? Do you have a clinical sales revenue line that you track? Yeah, nobody wants to say yes to this, but like kind of, yeah, okay. That's the goal. We need to start looking at it. We need to think about it differently. So that's not a prescription sale. It's not an OTC Lego or a caramel. It is a clinical service. And so just like we're sitting here and saying we need to start to diversify into clinical services, we have to diversify into health equity sales. So that's where I want us to go next, is I want us to think about our business model at a store, at a pharmacy, at a location, and say, how do I bring in revenue that's associated with all this health equity stuff that we're talking about? How do I bring in that revenue? How do I track it? How do I think about it? How do I staff it? So if we come back to this Deloitte article, and what did Deloitte say pharmacies need to be doing? We need to do chronic disease management, like diabetes self-management education, DSME. That's a clinical service. We need to do preventative services. Those are screening, test and treat, another clinical service that we could evaluate. And we need to integrate community health workers. Deloitte said that. Spoiler, I told them to say that. I can't believe they actually listened to me, but they did say it. Right? They said the three big things pharmacy can do right now to get into addressing health disparities are those three buckets. What's really interesting is if we think about the business model, who here does DSME? One person. Good job. That's why your county's doing great. I know. Ooh. All right. Who here looked at it and said, the profitability is not enough. It's hard to do. I can't get paid. All right, now everybody's raising their hand on that one. You can't get paid because you were staffing it with a pharmacist. It's not a good ROI, right? I don't like the phrase ROI in clinical services because I'm not giving money and getting it returned later, right? It's really a profitability. The profitability of DSME is hard when it's staffed by a pharmacist. Can you staff it by a technician? No, that's not their scope of practice. Can you staff it with a community health worker? Yes. Community health workers are trained and recognized to deliver disease education. So that changes the profitability of DSME. And so what we would consider a clinical sales, I'm now arguing is a health equity sale because the community health worker did it. So then the question is, how do I get this magical unicorn at my pharmacy? Guess what? You already have it. Community health worker is a frontline public health worker who is a trusted member of and/or has an unusually close understanding of the community served. This trusting relationship enables the CHW to serve as a liaison link intermediary between health and social services and the community to facilitate services, access to services to improve quality and cultural competence of service delivery, yada, yada, yada. Who here has that, can read that and say, that sounds like my technician? Exactly. You have community health workers in your pharmacy right now, but you're not calling them that. This whole trend started because we randomly trained one technician as a CHW. We cross-trained a technician as a CHW. One of our pharmacies was at a health department. They were just talking about stuff, or medical clinic, FQHC, talking about it. And the CEO said, hey, you guys are always doing something different or new. What's something new you have? And the response was, oh, we have a community health worker on staff. Same technician that's been there a decade, but just has a new title, community health worker. CEO said, oh my God, you have a CHW? I have a CHW. Can they like do stuff together and can we like collaborate? Sure. Yes. Let's do that. And then that created a per member per month payment structure for chronic disease management because they wanted the FQHC CHW to refer to the community pharmacy CHW and to have access to the clinic chart and document and bill. Same technician that's been there for a decade, doing the same thing for a decade. We just gave them a new title and it opened up the door. US Bureau of Labor actually defines what a CHW is. So this is not your technician that is a high school student. It says they typically need a high school diploma, and then there may or may not be some training. The may or may not be training is because every state is different. And we're going to talk about that, but just recognize it's a person at your pharmacy right now that knows about their communities. So what are these credentials and how do they work? So it kind of falls into like three general buckets or three general domains. In Alabama and North Dakota, there is no credentialing body for CHWs. So anyone can be a CHW. Okay. It's like Ratatouille, but not like Ratatouille, but it's totally like Ratatouille, the movie, not the dish, okay? Anyone can be a chef, not everyone should be a chef. Anyone can be a CHW, not everyone should be a CHW, okay? Then you have some states like Washington that say to be a CHW, you need to take our internal Department of Health training, and then we're going to stamp it and say you CHW. All right, fair. And then you have a third tier, which is that there is a state-based credentialing board. And to be a CHW, you have to apply to that credentialing board. That credentialing board says, what are your qualifications? And typically, one of the qualifications is you took a standardized course. What is a standardized course? That credentialing board is the one that determines that. A little bit of nepotism there, just so we're all on the same page, right? That's how that works. In Missouri, there is a credentialing board. That credentialing board authorizes, it's typically community colleges because this is a community college semester-long course, but anyone can apply. So we built a course and we applied, and we are now credentialed in the state of Missouri to train individuals as community health workers. Our course is recognized by the state. So when someone goes through it, they get a certificate of completion, and then they can take that to the credentialing board, and then they can apply and become a certified community health worker in the state of Missouri. What we also did is we put ACPE accreditation on it. So then we said, dear Virginia credentialing board, we've been talking to a lot of pharmacies in Virginia. There's a lot of work here with CHWs. Could we train here? Can we get our course credentialed? And they said, oh, we have this process. You've got to apply. You got to do this. And we said, we hear you. We're credentialed in Missouri as CHWs, and we're credentialed at this national body for pharmacy technician CE, and we're really pharmacy centric. And they went, that sounds amazing. Pass. And then we went to Pennsylvania, and we did the same thing. Pass. See what's going on? We took one course that was pharmacy centric, and we're getting it in multiple states. How does that help me in, say, Alabama? How would that help North Dakota? Well, it's CE. So you can still have someone go through it. They still get a certificate of completion. So now, even though there's no credentialing board, they still have a certificate of completion. So I feel comfortable saying I have a CHW in my store because they took this standardized course that is recognized by multiple states, is nationally recognized, and it fits this. Am I sitting here and saying you have to take our course? No. You can do whatever works at the state level. I'm just sharing the story of how we're doing this across a nation to try to put some standardization across it. What is interesting is every state is different. In Ohio, the Ohio Board of Nursing is the credentialing body. In Texas, there's two pathways to be a CHW: standardized education or experience. So pretty much anyone can be a CHW because you say experience, right? But from the training, I tried to take our course there and say, could we get our course certified in Texas? And they said, we will only certify courses if the faculty live in Texas. I am not moving to Texas to teach that course. So we said experiential, but we still train people through our program because then they know what a CHW is, they go through the same textbook as everybody else, and they understand how to start putting this in a pharmacy. But that's the credential. There's a really cool national landscape from the National Academy for State Health Policy. So everybody can kind of Google this and find it. It's really cool. And a lot of this is coming into vogue because COVID-19 shined a light on health disparities. But CHWs have been around for hundreds of years. They've started in China. We really saw it in the AIDS movement in the 70s and 80s in San Francisco. They've been around for a while, but we're talking about it now because COVID helped us understand we need to invest in health and equity. So I went to the state health policy and I looked up North Dakota. There's two rows of data here. The first is North Carolina. The second is North Dakota. And this policy breaks it into Medicaid reimbursement, 1115 waiver, MCO encouraged support of CHWs, CHW certification program, state CHW association or organization. And if you look, North Dakota does not have a certification program, does not have a state CHW organization, does not have MCOs require support, does not have the 1115 waiver, but Medicaid does allow reimbursement for the CHW. Specifically, Medicaid reimburses tribal community health workers, because that's essentially what that is there, through code T1023. So we can start to do this in tribal communities and use CHWs or HRs to help with that. It's like a community health resource is what they're calling them, but that's CHW, it's the same term. We're going to talk about, should I use code T1023? And my answer is generally no. And I'm going to talk about why I don't like that, but recognize that that does exist here in North Dakota. Again, every state is different in how you do this. When I look at health equity, I don't look at it from a one person, one pharmacy, one CHW billing. We try to do it from a network approach because that's where you get population health opportunities and you get better contracts, honestly. Trying to think if there's anything else I wanted to highlight about this fun thing here, but I don't think so. It might come back up. What the heck does a CHW do? Who are they? What are they doing? Why do we talk about them? This is by far my favorite case from someone I've taught. CHW was visiting a patient at home and found out that they were not adherent to medications. The patient was getting their medications every other month as opposed to monthly. Why? Because they needed to buy dog food. The option was, I have $20. Do I buy dog food or medication? And the patient was choosing dog food, which again, y'all failed the earlier test, so I'm going to answer this one for you. That's the correct answer. Buy the dog food. Help your pets. Have them. Pay for the dog food. Okay? Correct answer. Whatever anybody says, dog food is the correct answer. CHW realized that. So what did they do? They called Chewy. Chewy has a foundation. Chewy will mail food for pets for free to people that cannot afford it, because again, the right answer is make sure the animal has food. And now the patient's buying their medications. So what was the intervention that made the patient adherent to their medication? Dog food. There's no NDC for dog food. There's no CPT code for dog food. I was not able to bill anyone for dog food. So do I like fee-for-service models of CHWs? No, because dog food was not one of my fee-for-service options. But that's what was needed. That is what a CHW does. So for all this pressure we see as community pharmacies about adherence scores and make sure the patient takes their meds and all of these other things, the answer is dog food, which is not how any of our health insurance benefits are designed. And we're missing the mark because we needed to get them dog food. Cat food would have also been okay, but this person needed dog food. But again, cat food's fine too. This is my favorite example of what a CHW does. Yes, the lawn care one was fun. Yes, all these other ones are interesting. This is what to me encapsulates a community health worker. And it's about value expression and ultimately pharmacoequity. It's about creating health equity revenue to pay the CHW to do that. So what does a pharmacy CHW look like? Bunch of pharmacy technicians. They're your empathetic technician. They help patients. They talk to patients. They're problem solvers. Do you have that technician that spends like 20 minutes on the phone with Miss Betty and you're just like, oh, yeah, that's billable bingo right there. You've addressed loneliness. You're helping your community, you're helping your patients. The problem is you're sitting there being like, I have to do this, I want to do this, but I can't get paid for it. Kind of we are. That's what the last half of this is about for us to do. I need to go faster, don't I? Kind of. I just looked at that. I'm ranting a lot. All right, let's go a little bit faster. That's what they look like. This is what they look like in a pharmacy. It's super cool. This is what they look like. By the way, there's a beer can. Okay, so I wanted to know. We did find a way to sneak it in there. It is in there. Okay, so it's about striking the right balance about dispensing medications and creating care coordination and services. How many of you have a marketing budget at your pharmacy? Kind of like, yeah, you might not have it, but you kind of have it, right? Okay, take half of that and give it to a CHW or one of your technicians, and that's their salary when they're off the counter. So you facilitate them, just get them off the counter and have them go for it. This is my soapbox. This is where the slides are going to slow down because I'm going to rant again. I hate fee-for-service health equity. And this is what we see. We have payers coming to us and say, fee-for-service, do health equity screening. And I go, nope, not signing that contract. I refuse. So let's play the game. Elizabeth, are you hungry? So she's not hungry. Guys, I just did a food insecurity screening. Can someone pay me? Okay, right? That's fee-for-service. Screening, payment. All right. Generally speaking, did anybody skip the North Dakotian caramel cakes, caramel rolls, and is slightly hungry right now because you're waiting for the North Dakotian soup that's coming? Is anybody hungry? You're hungry. Thank you. Okay, she's hungry. You're hungry. Okay, so next patient. I did a screening again. I found out she was hungry. I need you guys to pay me. I'm not going to do anything about it. Like, I'm sorry. Look. Next patient. That's fee for service. I am paid for screening. I am not paid to close the gap. So I don't think any of us in this room would say, you're hungry? Oh, sucks. Next. No, you would do something about it. So then you've already set yourself up for failure because you've set yourself up for a business model where you're paid to screen and not do something. So we need to establish value-based models of care. We need to make health equity, our health equity service line, all about value expression and getting paid per member per month to just do stuff. You're hungry? There are North Dakotian caramel cakes back there. It's a mispronounced cinnamon bun, but apparently it's something local here. Enjoy. I've now resolved it. More money, please. Right? I did the screening and I resolved it. So I'd like $2. A payer-funded outreach. So this is chronic care management. This is a local health system paying a pharmacy per member per month to talk to patients during MedSync. Patients expressed concern about affording electricity and heat. The patient said, I'm worried about my electricity. CHW looked into it, found out that they were supposed to be receiving help from a nonprofit community action agency and that they just didn't do the yearly paperwork. Bonnie, the CHW, did the yearly paperwork. Patient now has heat and electricity. Ta-da! That is screening and action. And that got paid per member per month. This was in July of 2024. So this was like a month or two ago. And it's from the National Kidney Foundation. National Kidney Foundation partnered with the Missouri Pharmacy Association and CPSN Missouri to do a pilot program for CKD screening. CKD screening, where the CHW identified at-risk patients because they were on specific medications and talked to them and said, I think you should get screened for chronic kidney disease. And patients went, sure, what do I do? Well, as part of this program, we had a referral to the health department to do the screening. We said, connect there. CHW made sure the appointment happened. They scheduled it. They followed up with it. They talked to them through it and identified 33% with abnormal labs. 1 out of 3 patients screened had underlying chronic kidney disease. Does anybody know how much dialysis costs? $100,000 a year to the healthcare system, right? Ballpark. So early detection delays CKD or delays dialysis. Let's go with it delays dialysis by a decade. So one person getting screened early, identifying, prevents dialysis from starting for a decade. So 100,000 times 10, that's $1 million, right? Times 33 people, is $33 million saved. Do you know what a typical screening pays? $25. Going on a limb here, just going on a limb. I saved $33 million in healthcare costs. I kind of want to get paid more than $1,000 at $25 a pop, right? Not even, right? That's what we need to be thinking about. That's the value expression. That's value-based models of care. I prevented dialysis. I would like some of that cost savings. Do you know when the Affordable Care first started and they did these models with physicians, physicians got to keep as a bonus 50% of cost savings? That was one pharmacy that identified 33 patients. So one pharmacy saved $33 million. And according to how Affordable Care Act worked for physicians, that pharmacy's bonus was supposed to be $16 million. They clearly did not get paid that. Health-related social needs are incredibly complex. You start at the top and you have enhanced services at your pharmacy, med rec, delivery, what happens, and then you have patients that are identified through that process. This person is not getting their medications every month. Why is it? Because they're not affording it, because they need to buy dog food. All right. So then we do a screening. We just do a health risk screening. And I'm going to talk about what that looks like in a second. From that screening, I have an assessment. From that assessment, I create an action plan. My action plan is to connect the patient with Chewy and to get dog food there. And then I follow up. Did the dog food come? Yes. Are they buying their medications? Yes. Resolved. That's the care process that we want to approach. It's the same care process we do with a lot of our things, but we're adding this social component to it. And so now our goal is to make a cross-trained pharmacy technician / CHW. The pharmacy technician CHW is the pharmacy care coordinator in this role. They triage medication rejections, identify alternative payment models. Do you know how many of you help patients with coupon cards? Right, we do that. Yeah, all right. So you help them with coupon card. You just do that. Yes? Okay, cool. So we bill for formulary navigation support. That sounds really fancy. Do you know what it is? Coupon cards. We bill formulary navigation support because we're helping the patient with their out-of-pocket costs, but we're calling it something different and we're packaging it in a per member per month model for that reimbursement. So we're going to skip breakout 2. I'm really sorry, but I'm being mindful of my time because it's making a job description and your job description was right there. So moving forward. All right. So now let's actually get into the health equity line of revenue. Yes, of course. Yes.
And so I would assume that any of us, people that are practicing, would say, I would take one or more technicians any day.
Correct.
Oh, if we are all on board with this, I would love to be.
Yep.
Who's going to do the work with my vision is now.
So that's what this is. It's about creating health equity revenue. So if they're cross-trained, are they going to do health equity work 40 hours a week today? No, they might do health equity work 5 hours a week. And because they're doing it for that 5 hours a week, they've generated $10,000 a year, which pays for their salary for 10% of their time, right? And then as the health equity revenue grows, then you go from 10 hours a week of doing health equity work off the bench to 20 hours a week of doing health equity work off the bench. And you build it from there. So it's not an instantaneous, you don't just go higher. You don't just go staff up and say, do health equity. It's incremental growth. So you're generating new revenue to hire new people. And then you're saying we're having a shortage and we're having trouble finding them, right? Well, you're bringing in new revenue, which allows you to increase pay, which allows you to bring in more, like, it's about, like, it goes back to the money. So that's this section. We got to bring the money in, which is why I'm so adamant about money, 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 CE or not. Like, I'm still going to say money because we have to get paid for this service, right? And to that whole entire point, what if in your delivery service that you're doing it for $0 right now? In fact, you're losing money because you're paying gas and time and energy to do delivery that you're just doing. What if you got paid $80 for that? Would that pay for your delivery driver? $80 per member per month to deliver? Yeah. And that's what we're talking about here. Oh God, I broke it again. All right, we're gonna skip that. It's a circle. It's a circle, it's fine. It gets back to what is health equity in the pharmacy? What is it? We provide care at the pharmacy, MedSync, whatever. And when you have this foundation of MedSync, how many of us have like a sync program, right? And you call your patient a couple days ahead of time to make sure there's no changes before you fill everything to deliver it, right? So you're already talking to the person. So what if you take 5 minutes and add on a vaccine hesitancy intervention? During the MedSync call, you then do vaccine hesitancy education. Hey, it's now time to get your new flu vaccine. It's time to get your COVID vaccine. Are you ready? Do you want to get it? No, you have concerns. Let's talk about it. That intervention is G0310 and worth $25 for a 5 to 15 minute intervention. So now your MedSync call is generating $25 per intervention. So that goes back to her question of how do I pay for this? How do I get new people? You're generating $25 from your MedSync call that you're doing right now, and you're layering on a service that is worth $25 for every phone call. And then it's scheduling the patient to pick up their meds 2 days later and get their vaccine, and the vaccine's ready for them so that they can come in and get vaccinated. We have that going on in Missouri. We've done 80,000 interventions in 8 months. And all the pharmacies were getting paid $25 per intervention. So it's millions of dollars paid back to the pharmacy for their vaccine hesitancy services. Self-monitoring blood pressure, that is $100 per member per month. Paid for by state appropriated funds. So the state has a line item on their budget for cardiovascular care and pays $100 per member per month for a CHW to make sure the patient is checking their blood pressure and no optimization needs to occur. MedSync, we've talked about that, home visits, bingo dog food, we've done that. So you're doing something in the pharmacy. And in the process of doing something, you can do a screening for health equity. I'm often asked in class with our CHWs and other environments, what is the preferred SCOH screening form? The answer is the one that I get paid for. I don't care. They're all the same, but we like to act like they're not the same. They are all the same. And in fact, the questions are very terrible and no one should ever read them to a patient. That's just bad. You talk to the patient. I was talking to Annie, my friend from Missouri, right before I got on here. And she said she was interviewing some CHWs yesterday for best practices. And one of the things that they do is, as a pharmacy, we talk about our patients as patients, right? That is my patient. A community health worker doesn't call them a patient, it calls them a person. That's what we're talking about here. So am I going to do a screening on a patient? No, I'm going to have a conversation with a person that is going to elicit information that I need to document for interventions. And then once we have that, what are those questions, which we have on the next slide, and then we make data, which I'm going to get into. Okay, these are three forms. You have AAFP from the American Academy of Family Physicians, prepare, that is technically how you pronounce it. There's an A there, and I'm from Alabama, so I don't know. I always call it prepare, but like it's an A, prepare, prepare, okay? And then there's this thing that says Conquest Pharmacy, which is a random independent in Iowa. This question right here, which everyone can clearly read. In the last 12 months, have you or anyone in your household experienced any difficulty with food? Never, sometimes, always. One, we're never going to ask our patient that. Two, that is how AFP recommends food insecurity screening. Over here, in the past year, have you or any family members you live with been unable to get any of their phone when it was really needed? Food, yes or no? So two different validated screening tools asking a very similar question with what we can pretty much ascertain is the same type of data output. Here is one that Randy did, for his health department. Number 6, in the past year, have you or any family member you've been with unable to get any of the following when it was needed? Food, yes or no? Randy's question is verbatim what the prepared question was. I don't care what screening form you use. Use the one that I'm going to get paid with. I will document accordingly, but I just want to talk to my patient. Because we need to collect Z codes. All that data that we just said about North Dakota about health-related social need, those are Z codes. Z codes are an ICD-10 subtype. They are health-related social need. They are the health equity Z codes. Z is 9.41, food insecurity. Are you food insecure? Are you trouble having eating? Can you not afford your medications because you got to buy food? All of those are answering the question food insecurity and is documented as Z59.41. That's the data. That's what we document. That's how we express it. We don't express it that I did a prepare tool. I don't express it by saying food insecurity. I express it in data. And data is expressed as Z59.41. It's just like when we say the patient has diabetes. Yes, we break down diabetes, but how is it coded? It's using an ICD-10. And ICD-10 is health equity, and that's how we collect that data. I'm picking up a clip really quick. There'll be a reason. So we're going to skip this because that was a swear word. I will go to this one. Where we are finding benefit as a network of pharmacies is, okay, in Alabama, 60% of our children are covered by Medicaid. Okay, if I do a service for children in my one pharmacy, will Medicaid contract with me directly? No, I do not have network adequacy for the state to Medicaid to do something about it. This is why I'm kind of skipping this one, because you guys have network adequacy. So there's like some bridging here. What we need to recognize is I don't want fee for service. I don't want to bill a Z code or a T code or CPT or anything for health equity. I want my network to bill a payer. So if I'm doing something for pediatrics, I need the entire state to do it so that I can get a state-based contract with Medicaid. Again, swear word, apologize, but just roll with me. In Mississippi, there are more CPSN Missouri or CPSN Mississippi pharmacies than CVS's. So that network, that umbrella, allows contract to happen for network adequacy. So we created health equity to be our own little umbrella to create a network of pharmacies that do health equity work so we can contract as a network with single signature to get opportunities. So in 18 months, we have over 400 pharmacies. We've trained 1,000 CHWs with $1 million in scholarships. We have 400 SDOA specialists. We are doing stuff. This is old data because it was like two months ago. There's 80,000 vaccine hesitancy interventions, which counts for 25 million in cost avoidance. We see the CKD screening. So there's a lot of stuff going on. And really it boils down to this idea of value expression. Value is quality over cost. So for us to do this, to say that I saved you money, I need to express what I'm doing. And this gets us into pharmacoequity. How many of you are losing money on GLP-1s right now? Okay. But if a payer comes to you and says, I need you to do something to care for my patients with diabetes, are you really going to want to do that? Like that's tough, right? I'm not making money on the drug, and my revenue from the new service is probably not offsetting my loss that you're giving me. I can't accept it because we have this juxtaposition of medical spend and drug spend that are not aligned. So we need to start to think about how we as a profession in various networks, whatever that network might be, can get into a bundled product service payment model and change it. If I do this service, then I want more payment for the product. I'm not accepting your service contract until I'm not losing money on your product contract, product service. And what's really funny to me is when I talk to people, and I wear a couple hats. So I'm going to take off my CPS and health equity hat, like throw that away, get rid of the health equity side. One of the other things we do is quality measures and evaluation of pharmacy quality for value expression. That's going to come up in a second. So I talk to payers about network pharmacy design based on pharmacy quality measures, not claims-based health plan measures at a Part D level applied to pharmacies incorrectly. A pharmacy measure expressing value outwardly. And when I talk to them, they say, if we implement, a high quality pharmacy based on these quality measures, what is the PMPM savings? And what they're really asking is, what is the per member per month drug savings? And this is where I think that there's a huge juxtaposition that we've not done a good job articulating or describing. Who here hates DIR fees? All right, everybody should have raised their hands. Okay. What is a DIR fee? It's a value-based contract based on a patient's ability to be adherent to therapy, which is a plan level measure forced on us in the pharmacy incorrectly, right? We're all on the same page? Feeling good about this? Okay. What is that question? I need you to increase utilization because I need you to help someone be more adherent. But what do we do as a profession of pharmacy? We accept a per member per month drug cost lowering. So we're told, how can you lower PMPM, right? I'm in the negotiations. I'm talking to someone about network design, and they ask me, how can your network save PMPM? How can you save me per member per month cost on drugs, while at the same time increase utilization to make sure that they're adherent? What is the only way to increase utilization and drive down cost? You charge less, which is why we're in where we're at. So what we need to do is say, sure, I'll take a drug contract, but I also do services around that drug contract, which saves medical dollars. And because it saves medical dollars, I want payment for that. And that's where the health equity is our Trojan horse into this model of disruption. So thinking about like what we should be tracking, how many of you check the weight of a child at your pharmacy and document it in your system? Okay, no one, just so everybody's aware, no one raised their hand. How many of you in the past week dispensed amoxicillin to a kid under 5? A lot of people raised their hand on that one. How did you dispense the right dose of amoxicillin to a 5-year-old that is weight-based if you don't know their weight? Everybody now just like had their heart skip a beat, and they're like, I need to go back to the pharmacy, I need to do some stuff, right? So now go back to this example in Medicaid. 60% of children in Alabama are covered by Medicaid. What if I went to Medicaid and said, we make sure the child's dose is correct because we have this quality measure that says we document the weight of children so we know what the dose is? Can I get contracted differently? That's value expression. That's changing the conversation. That's why we use report cards. I'm going to skip that because we don't have a lot of time. This is a wonderful patient case. We're going to skip it really quick. We're not going to skip it because it's so sad. First, this is from Facebook. So it's a very reputable source of information. Great for references and information. But I'm posting as a warning to any parent in the area, if you use redacted, take a prescription before you're giving it to them and write the instructions down. Our son was born August 8th. We went in for a prescription for Pepsid, and it was prescribed as 0.2 mils. And they dispensed it as 2. When challenged, the chain pharmacy said, how should I have known what he weighs? The parent thought back and said, well, you did ask for his birthday, and you found out it was today, and he's not 40 pounds. They then tried to call the help desk for said company and was told to call back during normal business hours. Going back to the CKD, what if all of your pharmacies tracked the patient's serum creatinine and you knew what their serum creatinine was, so you were able to optimize the dose? Why is someone not adherent on a Part D perspective for their drugs? Because the dose is probably wrong. So how can we control that? We know their serum creatinine, we make adjustments. So we're expressing value differently to get into a different type of contract. So who is paying us right now for these health equity services using this value expression that we're talking about? We directly bill with billable codes for CHWs. Let's ignore that. We have drug manufacturers, federal programs, health plans. We get payment from an HBSU they pay us $200 to have a CHW at a health fair to talk about vaccines. And the answer is go to the pharmacy and get vaccinated. What used to be what we would call marketing, where I had to pay for somebody to stand at a health fair, we are now paid $200 to put a person at a health fair. There are billable codes now that are focused on CHW that are per member per month, and we're going to talk about that. I'm getting to the last slide because it's an active learning, and my goal is to have 10 minutes of question, because then there's 30 minutes of openness and stuff, and that way I'll just wander around while they're thinking about these bills. Is that good? I'm tracking. Okay. If you look at any medical provider, they are determining how they contract, right? They make a network contract at a local level, but pharmacy signs a contract for a national level. Who here is on HealthMart Atlas? Fantastic. So am I in Alabama. So your payment contract is the same as my payment contract, but our counties and our situations and our communities are so different. Why are we the same? We're wonderful, right now. we're great people, but like a little different. But that's the scenario that we're in. As a pharmacy, we sign one national contract, but if you look at any health system, they sign a local contract that they negotiate. Right? There's probably somebody in New York City that also is on Health Mart Atlas, which means the cost of living difference for all three is so different. So we're sitting here and we're saying, we need to be different. We need to look at our networks differently. We need to contract differently. And that's really what this gets to, is we want this health equity revenue. We might not get it as a single store. We can get it as a network, but we have to express value. And so what I want us to do is end on this. These are our 3 prompts. This is your last bit of active learning. And I'm going to walk, so before you dig into these, I will answer questions, but then we'll have like quiet time where you're kind of playing with this. You're talking to your neighbors. I'll walk around and answer questions. But these are 3 contracts we have right now. All right, so these are real. Create a proposal for product service contracting, so express value that will offset your loss of drug because you're now going to get paid more for drug because you're doing something around the service. So that's model 1. Model 2, health system HRSA covered entity. This one's really neat. So when we think about payer, we often think insurance companies, but payer is an OR and it's anybody that gives me money. So in this model, the payer is the health system. All right, so how much do you, we'll do this really quick. Madison, you are now a HRSA designated covered entity. You're able to buy drugs for 340B prices. Sweet, all right. Owned by the health system, that's how that works, can do it. I'm in the county over. Her health system provides patient prescriptions to my people, right? Because we're close and that's what happens. I buy Farxiga for $700. She buys Farxiga for 26 cents. What if I took my patient and their Farxiga prescription and I transferred it to Madison, and then I took my community health worker to pick it up from Madison, bring it back, get all the other medications for my patient, and then did a home delivery with my CHW, with that Farxiga, with everything else, by doing a health risk assessment, and you pay me $80 per member per month because I just did a service. See where we went with that one? Yeah, so that's happening. And where did you get the money from? The $700 Farxiga. So you're using 340B funds to pay for a community service to do home health care for your patient. So that's model number 2. Model number 3 is state vaccine program. We have this with 2 separate payers. We have a grant in Missouri through what was 1817 funding. Now it's like 2320 funding. So we have that going in Missouri. And then we have another program in Virginia, South Carolina, Kansas, and Missouri with a QIO, Quality Improvement Organization. Both focus on having a community health worker do vaccine hesitancy education in various areas. In Missouri, it's focused on doing it during the med sync call, layering it onto a sync, get them to get vaccinated at home, or setting up clinics outside the pharmacy. In 4 other states with the QIO, it's focused on assisted living and nursing homes. So you have community health workers go out, they do education, and you get kind of compensated for that. So those are our 3 kind of prompts for creating a business plan, business model, and things that we could be doing in North Dakota. So last couple minutes for questions, and then you'll work on your prompts and I'll wander around for deep dives and anybody has questions on that. Fair, Elizabeth, we good?
I think what we might also do is maybe during paperwork or discussion, maybe have some of the discussions going on lunch here in a few minutes. Jake, if that's okay.
Sure.
With that said, to have Lisa just provide a little update as to where we are with community health workers in North Dakota right now. So Lisa.
Hi, everybody. So there currently is a task force with health services, and I have been just kind of a public member listening into the task force, and because we know this work is coming, we know this is an important initiative of our pharmacy and pharmacy technicians. And so we are working with one pharmacy that right now that has already started. And so there will be credentialing that will be changing at the time. That is all being decided. However, it's really important if you are interested in this initiative and this idea in your pharmacy to get started now, start doing the work now, because that experience they help come towards some of the credentialing, some of the education. And so if you are interested, and this will just take a second here, but please just let Liz or I know, or email. I know you get a lot of emails from me, so I'm sure you have that. If you are interested, then we can help with that and help get some projects going in your pharmacy. So that is coming very soon. They've been working on this task force for almost 2 years now, and it should be all done by the end of this calendar year. So more information to come, but please reach out for our interest.
Okay, and then also, Jane, is it okay if we take questions now? Would that be okay with you? Okay, so if there's any questions for Jane. I'll check like that.
I have a question.
Okay.
I'm a pharmacy technician.
Awesome.
Great. So my question is, I'm not.
Yes. I tend to look at it from that pharmacy perspective because you're trying to build it up, right, from an infrastructure to pharmacy. But the CHW came out outside of pharmacy, and it primarily is a non-pharmacy thing. It goes back to that story of the clinic being like, oh, I have CHWs, you have CHWs, let's work together. If you look at like guidance that's now happening at a federal level, like stuff that I'm going to name drop because I know he's from here and I told him I would say his name. So if anybody knows Gerald Finken, and you can text him, I'm saying his name right now, Gerald Finken. Right, so he does a lot with clinical trials, and the FDA actually issued guidance that CHWs should be involved in clinical trial recruitment to help vulnerable populations. Has nothing to do with pharmacy, but it's about cultural competency and understanding your communities. I totally snuck that Gerald Finken reference in there. Yes.
Any other questions?
Okay, so if community health worker, how are you like, are you using the platform of billing or are you not paper billing? Is it?
So the question is, you get a CHW, what's the billing? That goes back to how you want to bill or to whom you're billing. If it's you and a local health department, just send them an invoice. If it's you and a bunch of people, you're our CEO of our pharmacy association, yeah, you go to him and say, how do we as a network bill for this to someone, right? Because that's what it boils down to. And it goes back to like that, the CMS codes, the CHW billing codes, G0023, Principal Illness Navigation. In Alabama, a CHW, let's use Kentucky. In Kentucky, CHWs are authorized to bill. But in Kentucky, a CHW has to be overseen by a provider, and they don't count pharmacists as providers. So all of a sudden, a CHW cannot bill, even though they can bill. Does that make sense? But the network could do a roster bill invoice on behalf of the pharmacies. So you aggregate interventions on a monthly basis and you bill all those interventions. Vaccine hesitancy, G0310, the $25 vaccine hesitancy. Yes, it's a billable code. We're not billing an insurance company. We're not doing a paper chart. We are aggregating that data, and then we send a roster bill every month to the state saying, these are the number of interventions and this is how we need to pay that. So I would go more, if it's local, one-on-one, give them an invoice because it's your health department. Your Medicaid is going to need a network for network adequacy, and that's where you go to your CEO and you do it as a network-wide initiative. Is that fair?
And I think just to add on to that too, so in North Dakota, pharmacists are providers. So shared with me that on calls, being recognized as that pharmacist can actually be the person to recommend that care to the CHW. And then another point too, to segue into our next talk after lunch, Mike and Jesse, when we talk about the platform that's being built right now. Starfield is actually being piloted in some of our pharmacies that will kind of lead us to that opportunity for the focus from that.
And so then I would just say piggyback off of that. That's the easy solution. Hi.
In my practice, we're doing a lot.
Mm-hmm. So the question is, we're doing all this work, but the pharmacist is doing it, not a technician. Pharmacists can totally do it, but it goes back to profitability. We had the raise your hand, who does DSME? And nobody said yes because there's not enough money. And it's because they're trying to staff it by a pharmacy. So there's two things out of that. One, it's making more profit for the interventions to allow better infrastructure. And two, for our technician colleague up here, I think it's about professional development for pharmacy technicians. It's about a career growth for pharmacy technicians and giving them the ability to grow, which then opens up new opportunities for new people to then you can hire more people at the pharmacy. So you can totally do it. I've trained pharmacists at CHWs.
And Lisa mentioned the pharmacy that we have in North Dakota, a CHW pharmacy tech pilot right now. And I would say satisfaction for that pharmacy tech is proven. Loving the intervention, loving being able to relate to patients on a different level, and loving to be able to have the opportunity to talk about the things that they're kind of seeing, but they weren't being asked to talk about.
Yep.
Right? They're seeing a patient all of a sudden a little trouble in their appearance. Not sick, just appearing a little off from what they normally would expect. So guess what? Now they can have this conversation and they feel like they have the opportunity to do that. So I definitely see that satisfaction.
Awesome. Thanks.
I know today's topic is more on sort of internal and how it's happening, how to do it, so that is the priority. However, ultimately, it's going to improve the health of the population. So I think one of the keys there is that the pharmacy has some degree of connectivity to the social service agencies. You know, can you sort of better talk kids in school, whatnot, that community health worker can't do all. Any comments on the necessity being better integrated on social service agencies from that? I think it's part of the role.
Yes. Also, Sujith Ramachandran says hi. You know Sujith, right? Sujith Ramachandran says hi to you.
Oh,
Yeah. And I can't find help. That's what I wanted. I can't type on this. Mark, what's your zip code? 58103. Search can't find it. Apparently you have no help in your zip code. I'm going to do mine. There are 2,102 programs in my community. You have none, so that's concerning, but we'll come back to that. I probably typed it in wrong. Let's just act like I typed it in wrong, guys. All right. So in the CHW train, what I'm kind of getting at, in the CHW training, there's a service learning component. It's not just didactic, it's go out and they have to find all these resources. They have to document them. We have them categorize it based on Z code so that when they find it, they can refer. And what we say is it's about knowing them. It's not about going here and knowing all 2,100. It's about knowing 30 of them by name and calling people by name. So that way it's that established relationship. So that's the goal, is in that training, they build this rapport and it continues to flourish.
Referrals and community resources in Minnesota. So we've been working with the School of Pharmacy on utilizing pharmacy students to develop community resource guides while they're at their location. We have heard really amazing responses from students about, I this church, they've got this basement food,
Yeah.
right? Or this lady who makes food and just hands out to people. So the amazing opportunities that students have to find those resources for their community pharmacy. But also from the state perspective, just want to share that we are looking and pushing for a statewide CIE, which is the Community Information Exchange. So think about the in regards to healthcare. This is a bi-directional closed loop referral system for community resources. So be able to connect healthcare to the community and community with healthcare, as well as community with community, something that we definitely know we're missing. So we're working on that with the Medicaid office. Actually in proposed budget. So we're hoping within the next 24 months or so that we would actually have a CIE, which would be a huge step forward.
Yeah.
Especially for the crowd.
That's nice. That's exciting. There was another arm.
Oh, I was just gonna mention there is some research already out there, like, you know, they have like, you know, like for research, and I know some students, educated, we're talking about, is that something that they is seeing as far as what say students that long-term place that has particular resource all over the place, right? So it's something we'll look at as well, but personally, it's a really great place to go and resources.
Well, what's really interesting is we saw the places data, and there was a dearth of health equity data from a CDC perspective in North Dakota. We just typed in Mark's zip code and it didn't pop up. So I'm assuming that it was not me and that there's actually something that's happening where it's not being reported or aggregated. And now you're telling me that you're having this exchange happen. Those are all really cool opportunities that can come together to funnel all of this. And again, you know, if there's $2 million for community diagnosis and it typically went to, you know, somewhere else, why can it not come to the pharmacy to funnel these types of opportunities for data collection and aggregation?
Let's see if you have any other closing remarks or anything like that.
Thank you for having me. Yeah.